So I'm going to talk this afternoon about research that I did on healing relationships. And before I get into that, I'd like to tell you a little bit about how this research came to be. So I was in practice in North Central Arkansas for 18 years in the same place. And during that time, I noticed that the quality of relationship with my patients seemed to have just as much to do with how well they did as the pills and medical treatments I gave them. And so I knew that there was something healing about relationships, but I wasn't quite sure what it was. And when I came to be on the faculty at Robert Wood Johnson Medical School in New Jersey, I was able to get a grant from the Robert Wood Johnson Foundation to study how healing relationships develop. And that's the research I'm going to talk to you about today. I'm going to show you the model that we developed. I'm going to go through each component of it, and I'm going to stop at the end of each one and to see if there are any questions or comments. We'll also do questions or comments at the end. And I'm also going to talk about how it is that you do these things, that you participate in these relationships. So here we go. So we know that that relationships and health are related. As a matter of fact, that decreased quality and number of relationships is just as strong a predictor of morbidity and mortality as the traditional risk factors that we use: smoking, hypertension, and so forth. And high quality and number of relationships are protective against morbidity and mortality just as much as stopping smoking and treating hypertension. So relationships are, in general, are important. So what about physicians as healers? Well, there are two famous reports. They were done quite a while ago, but they're still quoted quite often. One of them was the Institute of Medicine report called Crossing the Quality Chasm. The other was the Future of Family Medicine report. And both of these talked about the importance of continuous healing relationships. Now, they didn't define what those were, I suspect, because they didn't know how to define what they were. So the question that I want to know is, what is a healing relationship? Does it matter? Well, there is some quantitative research that says that it does, that the doctor-patient relationship does matter in terms of health outcomes. Patient satisfaction is associated with better health status, better diabetes outcomes, trust with increased adherence, more preventive care. That's not surprising. Respect for the clinician. There are studies showing that there are higher odds that patients with HIV infection would receive highly active retroviral treatment. Patient-centeredness with compliance, better pain relief, and patient empowerment with better blood sugar control and decreased hospitalization. So doctor-patient relationships, there's quantitative research that says these do make a difference with outcomes. So my study objective was to develop a theoretical model of clinician-patient healing relationships, how they happen, and what makes them up. I'll give you a brief outline of the design of this study. It was a qualitative study. So qualitative studies can be just as rigorous as quantitative studies, but they ask different questions. They ask how and why things happen. And instead of a random sample, we choose a sample that we're likely to find what we're looking for to be able to describe it. So I found 5 exemplar physicians, either through books that they wrote, papers that they wrote, awards that they won, nomination by other physicians. And these were physicians who had a particular interest in doctor-patient relationships. And then I asked each physician to choose 4 or 5 patients that they thought might have experienced healing. So then I did long interviews with the physicians and their patients about their relationship with each other. The shortest interview was an hour. The longest one was 3 hours. These were recorded and transcribed. And then we analyzed these hundreds of pages of text by a diverse team. And that's how qualitative research is best done, by people with different expertise. One was a registered nurse, one was a medical anthropologist, one was a communication specialist, and then me as a family physician. So we looked at these hundreds of pages of data and found that there were common themes, and that's what I'm going to talk to you about in just a moment. So the first result, so I didn't want to start out with a definition of healing because I wanted to see what would emerge from the data, what doctors and patients thought healing was. And what emerged was that healing was being cured when possible, clearly, reducing suffering when cure was not possible, and finding meaning beyond the illness experience. That means even though the illness was still present, it did not define the life of these people. They continued, they went on to have a productive and enjoyable life despite the presence of their illness. So in fact, most of the patients I interviewed did have chronic diseases. Cure wasn't an option. Management and decreasing suffering certainly was an option. So, so this is the whole model, and I want you to look at this just for a few minutes to see the. I'm going to go through each one of these things individually, but you'll notice that there are certain processes that are necessary for healing relationships to take place, that physicians have to have certain competencies in order to participate in these processes, and that this leads to outcomes that are important to patients. Spoiler alert, hemoglobin A1C is not one of the outcomes that was important to patients. So we're going to start with these processes. I'm gonna stop after each one and give people a chance to comment or ask questions if they want to. So the first process we call valuing, and valuing is the emotional and cognitive bond that form between clinician and patient. So there are several parts to this. One is a non-judgmental stance, and I'll talk about that in a minute. Another one is being present, being completely present in the encounter. And finally, there was the idea of how you connect with patients. So let's talk about these things. So here's a quote from a patient about being valued. I'm going to let you read it. I'm not going to read these aloud. Although I love the last part, that they give a rat's ass about the clinician. So non-judgmental stance means consciously approaching every patient as a person of worth without stereotyping. So how do you do that? Well, when you, part of this is mindfulness, and we'll talk about the importance of mindfulness a little bit later on. But you take a deep breath outside the door of the room. You let everything else that you're worried about, the next patient, charts you have to do, all that stuff be set aside. And when you open the door, that patient is the most important person in the world for that time that you're with them. That's what a non-judgmental stance means. And that also helps establish rapport, and we'll talk about that a little bit. So here's a quote from the data from one of the patients about that non-judgmental stance, and I'll let you read that. So I think the most important part of this is that last sentence. It's all the assumptions that we make about people. I think you're not going to get people who want to tell you anything or that their behavior is what's causing the problem. Maybe their problem is what's causing their behavior. Right. So connecting is purposely searching for ways to like or even love each patient. I'll show you a quote from one of the physicians in a moment. But he talked about finding something or several things that resonate with the clinician's life experience. So you have to find some way that you care what happens to this person. And obviously treating each patient as a whole person, not as a receptacle of a disease process. So here is a quote from one of the physicians in the study. So I want to point out here, he talks about, I especially try to love those I initially hate. So it's important, again, we'll talk about mindfulness later, to monitor your own reactions. If you're having a negative reaction to the patient, that means there's something going on in you. They're triggering something in you. And what he's talking about is getting past that and finding some way to connect, no matter what his initial impression is. Okay, so the next part of this idea of valuing is presence, being present in the encounter, giving your full attention in the encounter. So how do you do that? If you go into the room and that person is the most important person in the room in your life at that moment, then certain things are going to happen. Mirror neurons are going to kick in. Your facial expressions are going to mirror those of the patient. Your body language is going to mirror the patient's body language. So you don't have to think about things like that. You have to just be present in the moment with the patient. The second part is listening, accepting their illness experience as important. And one of the ways that you do that is by letting the patient know that you hear them, by using their words to make sure that know. So you don't paraphrase, you use their words back. Say, it looks like you're feeling that, and then you repeat their words. So that establishes rapport, and it also lets the patients know that you care what their experience is. And finally, there's this idea of suffering with patients. It's a little different from empathy. There is a model of patient suffering, which I just got this morning from Dr. Williams, who is one of our participants today, and he's developed a model of description of patient suffering. But suffering with is recognizing patients are suffering and connecting it with your own experience of suffering. So I'm going to give you a couple of quotes for all of these things. So here's a quote from a patient about how she felt like her physician gave her full attention when she was there. So I'll give you a minute to read that. That is presence. And here's an example of paying attention to illness experience. So this patient was very bright. She didn't have much education, but she had risen to the point of being in charge of instruments in an operating room. She basically ran the operating room, and she was very talented. But she started to have some orthopedic problems. She had some surgeries. Every time she had a surgery, she hurt worse than before it. So she developed a chronic pain syndrome. So this is her experience of how her physician listened to her about that. And again, the last sentence is the most important. And she just stuck with me and said, "I believe you." So this is a quote from a physician who talked about not letting patient suffering just roll off our backs. That sometimes it connects with our own experience. So I'll let you read this quote. I think this was this important. Again, the last sentence is, "We never stop subject with this, and this is what makes us better doctors." Okay, so I'm going to stop for a second before I go to the next process and ask if anybody has any questions or comments about this idea of valuing, of being present, of connecting, uh, uh, and paying attention to the patient's illness experience. Anyone have any questions or comments about that?
John, can I ask a question? Bill Phillips.
Sure.
Here. Bill Phillips, I'm a guest from Seattle and an old friend and colleague of John's. Happy to be here with the group. Thank you. In several of those quotations, the patients asserted that I know or I believe the doctor treats us all the same. They made judgments about what the doctor does with other patients, and that somehow affected their relationship with the patient. Any comments on that? About it's one thing to sit with the patient and make them feel special, but these patients are telling us, I believe the doctor does this with all patients. They take us all without stereotypes. They value us all. That kind of generalization. Any comments on that part of the story?
So most of these patients had very long relationships with their clinicians, and their families as well. I suspect part of this has to do with the fact that they know that she treated the patient's husband and children and other relatives because they talked the same way. I suspect that's part of it. Um, and, you know, I'm not sure what conversation goes on in the waiting room, but I suspect that some does, and some of it may be that. Um, uh, but but you're right. And that particular patient, she felt like that not only did the doctor do this with her, but she did it with everyone.
And are many of these patients that you talked with from smaller communities?
Some of them these physicians and the patients were from all over the Northeast.
Yeah.
So some of them were from bigger cities, some of them were small towns. They were all races and ethnicities. So it was diverse. So there were a few that were from small towns, but there were some that were from cities as well. This particular one happened to be from the Boston area.
Thanks, John.
All right. Any other questions or comments at this point on what we've covered so far?
I have a question, kind of tangential. Do you guys look at a person's attachment style or language to feel loved or anything like that in their assessment of if they're feeling presence or something like that with their physician?
Well, so so every person is individual. So the answer is clearly yes. So the idea of rapport, though, can happen with anybody. If patients feel listened to, then that rapport develops. Some patients are it's more difficult than others, particularly with, and I'll talk about this a little later, with marginalized communities who have had lots of bad experiences with the medical profession. This takes a little longer. Trust doesn't develop quickly. It takes time. And we'll talk about trust later on. But the other thing is that and I'll go over this again, the importance of self-monitoring, this idea of mindfulness. You don't know how you're reacting if you don't monitor yourself. And that's a skill. That's one of the competencies of clinicians that we'll talk about in a few minutes.
Okay.
Any other? Does that answer that? I'm not sure whether I answered your question or not. I think I did. Okay, so this next process we called appreciating power. So there's a lot of language in medical speak in medical institutions that's sort of borrowed from consumer language. It's we talk about providers, we talk about patients as consumers, and the idea is that this is kind of an equal relationship, like a buyer and a seller. Well, it's not. There is a power asymmetry that's built in. Patients are sick. They're ill. They're afraid that something bad is going to happen to them. They're coming for help, and the physician or clinician is the person who's going to provide help. So that's a built-in power asymmetry. So it's important to understand that we start out not as an equal relationship. Master clinicians, though, can do things to decrease that power differential, and let's talk about that. So most of the time, master clinicians do things that decrease that power differential, although occasionally they use it to push patients to do things they're not quite ready to do. So let's talk about this for a minute. So one of the things that these master clinicians did was partner with patients. So instead of the doctor giving out medical care to the patient, they made patients partners in participating in taking care of their illness. They also used educating to teach patients about their illness so they could do more of their own self-management. So that was another way to reduce this power differential. And occasionally they used the power differential to push patients to do things that they needed to do that they weren't quite ready to do. So I'm going to give you a couple of examples of these. So this is an example of partnering. This was a patient. So this patient clearly perceived that he or she was a partner with the doctor in treating the illness. So here's an example where educating happened. This is another patient. So this is, again, the idea of teaching patients about their illness so that they can be a partner and participate in the management. And then this was an example of pushing. So this was a patient. This was a Hispanic man who had AIDS. He had HIV infection. And this was at the very beginning of highly active retroviral therapy when it wasn't easy to take these medicines. They had to take multiple medicines multiple times a day. They were very unpleasant to take. They tasted bad. You really had to be motivated to take these medicines. And this patient talks about how his doctor pushed him to do that. And that, and the last sentence, that's one of the reasons I'm still here. So this didn't happen very often, but it was important when it did happen. So that power differential, most of the time, it's much better to reduce it. Sometimes clinicians need to use it. All right, so let me stop here and ask if there are any questions or comments about that idea of the power differential and how it can be reduced or used. Okay, so if there are no questions or comments about that, I'm going to go with the last process, which we called abiding. And I shall love that term. One of my colleagues came up with that. That's just being with patients over time. It's not abandoning them. Let me talk a little bit more about that. So it's access over time. It's commitment to care for major health events. When you're with a patient for a long time, that's likely to happen. One physician talked about caring actions. It was important for him to do little things like trim toenails or draw blood, just to show that he cared for patients. And then the final and more important thing is this commitment to not give up. I mean, for some chronic illnesses, we get to the point where the medicines we give aren't helping very much. The the disease process is progressing, and it was very important for patients that the doctor stay with them no matter what. The commitment to not give up, even when the normal treatments we do don't work anymore. So let me give you some examples. Now, this is the same patient from before that had the chronic pain. So she talks about this abiding, this staying with her. I think there are a couple of important sentences here. One is, but through every single thing, she has managed to find a way to get me what I needed. So that's an example of how important abiding is, sticking with patients over time, no matter what. Okay, so I'm going to stop there again and ask for comments or questions about this idea of abiding, about being with patients over time. You'll notice that means you have to be in one place over time. So sometimes I think medical organizations think doctors are like widgets. You can just move them around and they'll work just as well one place as another. These things take time. They take staying in one place, seeing the same patients over time. This is not something that happens overnight or even in a year. In residency programs, 3 years, it just begins to happen. Once, for the residents that are listening, once you're in practice, it's important to stay in one place for an extended period of time. Obviously, sometimes that can't happen, but when it happens, it works the best. So, any comments or questions about that? Okay, so it turns out that in the interviews we found that clinicians needed certain competencies to participate in these healing relationships, and then we found 4 of them. One was a projection of confidence. So that was important to patients. They didn't want doctors to say, well, I think it might be this, or I think it might be that, and I don't know, maybe we can try this. They wanted clinicians to project confidence, self-confidence. The idea of emotional self-management, we'll talk about that. That's really important, and that's also related to mindfulness, the other competency, and we'll talk a lot more about that. And then finally, medical knowledge. So that's obviously you have to be competent in the science of medicine, or none of this makes any difference. But it's also competence to be able to apply the science of medicine to this particular patient in front of you. And that takes time to learn. You don't necessarily just follow the guidelines. You've got a unique person in front of you that has unique needs, and you have to be able to use both the knowledge that you know that you learned and the tacit knowledge that comes in that we call intuition, but really it's knowledge that gets internalized, and it's a pattern recognition kind of thing. So all of that is part of knowledge. So let's talk about this a little bit. So projection of self-confidence is important to patients, and here are a couple of quotes. So this is about self-confidence. So she exuded confidence to the patient. That's a good thing. So emotional self-management is this idea that that the clinician has to manage their own emotional response and project calmness that's calibrated to the emotional state of the patient. So William Osler, who was the father of internal medicine, once gave a famous lecture to medical students called Equanimitas. And lots of people have interpreted that as him saying that you need to be emotionally distant. But that's not what he said. What he said is that your emotional response has to be calibrated to the patient's emotional state. So, so if a patient's in really severe distress, the clinician can't say, "Oh my God, that's horrible." They number one, they have to recognize what their own emotions are, manage those emotions so that they project calmness and confidence. This is something we're going to be able to take care of. We're going to be able to manage this, but it's not emotional distance, not at all. And we're going to talk about mindfulness in just a minute. You can't recognize your own emotions and manage them if you don't know what they are. So mindfulness is part of monitoring yourself as well as what's going on with the patient. We'll talk about that in a minute. So here's a quote from a physician about this emotional self-management. Okay, so mindfulness, and I think this may be the most important competency. It certainly other things depend on this. So mindfulness has several aspects. First of all, it's being in the present moment. It's not thinking about the future, what your charts are going to be like, or what you have to do tomorrow, or what your schedule is going to be. It's not worrying about something that happened in the past. It's being right here, right now, in the present moment, and that takes a bit of practice. So you have to be aware of what's going on inside you, and you also have to be aware of what's going on with the patient, and you have to do that all at the same time. So this is a learned skill, and it's a really important one. So this is a quote from a physician about this this idea of mindfulness and listening to the patient's story and listening to herself and figuring out what is it that what role does the patient need you to be in. So and notice that she says, is this a story? Because patients tell stories. They don't give you symptoms. They tell you stories, and you need to listen to the story, and you need to figure out what the story is about. All right. So clinical knowledge, we talked a little bit about that. So it's both that explicit knowledge and that tacit knowledge. That's the pattern recognition that comes over time. It's interesting that patients see clinicians as more knowledgeable if they acknowledge their limitations and they are willing to seek assistance. Here are a couple of quotes from patients about this. Okay, so we're going to talk about outcomes, but before we do that, I want to ask if there are any questions about these competencies of clinicians that they need to develop to bring to healing relationships. Do any of you do this? Does it sound familiar to you?
John, let me ask you again, Bill Phillips here. I think a lot of us talk about and value the process of witnessing. And I see that in these quotations here, but I don't see that term. Where in your model would you put the value of witnessing a patient's suffering or shame or blame or uncertainty, et cetera?
So, so that's a good word. Maybe that needs to be in the model. So being a witness to suffering is one of the things that makes suffering more tolerable, I think. Obviously, you've been thinking about suffering for a long time with your suffering model, which I loved seeing today. But that idea of being a witness, of listening to the patient's story of suffering, part of that I think is when we talked about abiding. That's being a witness to the patient's suffering over time, and the idea of being present is also part of witnessing. But I think witnessing is a very good word. I like that.
Let me also offer, I think about a process that's important, and I hear it in what you said, but I haven't heard it named, and that is these processes aren't always competencies and skills to do something. They're often competencies and commitment to sit there and not necessarily do anything very active, but to be with the patient, to be present. So especially when we're learning, we often think, oh, what do I do next? What's the right thing to say here? And the more experience we get, and this is true with friends and suffering people and so on, is that sometimes just sitting there and being there is the most important. I'm sure that's in here.
When I work with medical students sometime, and I have in the past, and I still do. And one of the things that I always tell them is, what I want you to do is to not say anything for at least 3 minutes. And so the idea is to make them just be present. They always feel, particularly medical students, but learners, residents too, feel like they have to manage the encounter, and just being present is sometimes, many times, all that's necessary.
And we're all learners.
Yes.
Thank you.
All right. Any other questions or comments from anyone about this this whole idea of the competencies of clinicians, one of which is just simply to be present and to listen to the patient's story, the witness, as you talk, Bill. Okay, so so the next thing I want to talk about is outcomes that are important to patients. So the interview guide that we use to interview patients and physicians, we wanted to learn what comes. We have all sorts of outcomes that are important to clinicians, and I wanted to know what kinds of outcomes were important to patients. And it turns out they're not the same always. The things that were important to patients were a sense of hope, not false hope. They didn't want to be given false hope, but they didn't want their hope taken away either. Trust. There's some things about trust that we'll talk about. The components of trust that were really important to patients, and probably. Whoops. Hang on. I lost my earplugs. Being known as a person. Can you hear me?
Yes.
Oh, okay. All right. Just checking. Being known as a person. Being known, sort of knowing who you are. Let me talk a little bit about each of these through some quotes. Well, actually, first, so hope is the idea that current suffering may not be permanent. So again, patients don't want false hope. They want physicians to be honest, but they don't want them to be. The term used to be called hanging crepe, to take away hope entirely. So having some hope that suffering might get better was important. Being known as a person was probably the most important thing. And then trust involved feeling safe. So feeling safe to tell the clinician things that you probably wouldn't have told anybody else, knowing that you're not going to be judged for saying so, feeling safe in not being judged. And the other part is knowing that promises will be kept. So I'll give you some representative quotes. This is one from a physician about hope. So here's a quote from a patient about being known as a person. So he says it twice. She knows who I am. All right. And this is a quote from a physician. So he felt like that trust built up over time, which is certainly true. It's especially true for marginalized populations who have in the past had not particularly great interactions with the medical profession. They definitely take time to build trust, but there are some people when trust can happen very quickly, particularly when they feel the physician is present for them, is listening to them, is paying attention to their encounter. Sometimes trust can build very quickly. Sometimes, like this, it takes time. So actually, let me back up a minute before we go to that next slide. So are there any questions that anyone has or comments about these outcomes that are important to patients? One thing actually I do want to mention about being known is that clinicians see lots of patients, and sometimes if you only see them once a year, it's kind of difficult to remember. So you need to have a place to write down who this person is. That's very hard to do in electronic medical records. But you can usually find a text field somewhere that's easily accessible where you can write this down. For those of you that use Athena, there is a comment field below the problem list where you can put this information about who this person is. That also helps if they have to see another physician, and it helps you the next time you see them, because you can ask about, how their favorite dog is doing, or how their child is, or those kinds of things that let the patient feel that they're known as a person. So almost every EMR has something somewhere that you can find to record this information. Any other comments about these outcomes that are important to patients?
This is Dr. Ortega. I was just, I tell the residents that when somebody tells you they trust you, that's huge, and not to ignore that, because that means that you've done a lot of hard work to earn that. And so even like I have patients who maybe don't want to take medication, but they keep seeing me, for example, or, they don't really want to take my advice. But I had one in particular that came to mind. We were talking about something else, and she said, well, I trust you. So, and it was, it was a very profound moment, because especially when people don't seem to want to take your advice, you can often feel like, well, maybe they don't really trust what I'm saying. But just to get that from her was huge. So.
Right. So again, that's a lot of times things that we think are important for patients are not necessarily the same things the patients think are important. So trust is one of those things, the others as well. Any other comments, questions about these outcomes that are important to patients?
Just a quick time check for everybody. We've got about 4 minutes, Dr. Scott.
Okay. All right. Oh, that's good, because I'm almost through. So the question is, and I suspect the experienced clinicians already know this, but for any residents that are listening, does this whole focus on healing relationship, doing all this hard work, does that increase the risk of burnout? And I think from our interview data, from talking to these physicians, it was exactly the opposite. That the clinicians that I interviewed were in practice for many years, and they still loved what they do. And so what we found is that developing these kind of relationships with patients, these healing relationships, that it works in both directions for the clinician as well as the patient. And clinicians, these clinicians didn't take this stuff home. They were in intense relationships with patients. They were present for the patients, but when they went home, they were present for their families too. They were mindful of things that were going on. They took care of themselves. So what we found is that not only did this not increase burnout, these kinds of relationships help prevent burnout. So here's the model again. Bill, I think we should put witnessing in here somewhere. And if anybody has any further questions, I think we're about out of time. But if there are any further questions, please feel free to ask them. Okay, so here's some references that I think are really important. I asked consortium to try and I had PDFs of these two Epstein references, which are in a sort of obscure journal that you have to belong to get them. So these are on mindfulness. They're old, but they're fabulous, and they're really worth reading. Also included a reference to the paper that we wrote about what we've talked about today. And this is a reference to Dr. Phillips' work on his model of suffering, and that is absolutely worth reading. So I've included a reference in there and a link. So if the residents have, hopefully they'll have access to these slides so they can get these references. So thank you very much. I have enjoyed this time with all of you.
Thank you so much, Dr. Scott. It was a pleasure to hear you.
Okay, great. Thank you very much.